The University of Washington Family Medicine Residency, the graduating PGY3 class created a quality improvement project entitled HIV Pre-Exposure Prophylaxis, Optimizing Care at UWFMR Clinics. Presenters today will include Dr. Claire Simon and Dr. Joseph Nelson. Authors are listed here. Please take the time to review the unique language used in this presentation. We know that PrEP can decrease the risk of acquiring HIV infection. The use of PrEP is a Grade A United States Preventative Services Task Force recommendation in high-risk populations. Options include Truvada or Descovy. The Centers for Disease Control offers guidelines for lab monitoring when starting and when continuing these medications. Inappropriate lab monitoring may lead to missed HIV diagnoses and antiviral resistance. Requirement for labs may lead to new HIV diagnoses, but may also be a barrier and lead to lapses in PrEP treatment. Presented here is the United States Preventative Service Task Force recommendation for use of PrEP in high-risk individuals. High-risk individuals are also defined on this slide. Presented here are the Center for Disease Control guidelines for lab monitoring. The American Board of Family Medicine requires all residents to complete a structured performance improvement project prior to graduation. The UW Family Medicine Residency third-year residents drafted a PI project to improve care for patients on HIV PrEP. This was motivated in part due to a poor outcome for a patient in our system. We aim to increase appropriate prescribing of HIV PrEP and decrease lapses in treatment with this project. Our initial data analysis included the review of the electronic healthcare record to identify any and all University of Washington Family Medicine resident clinic patients being prescribed medications for HIV PrEP between August 2020 and July of 2021. In the AHR record, we also looked to determine if medications were continued and if the appropriate lab monitoring interval was used for both HIV screening and creatinine clearance. We also looked to identify any reasons for non-continuous prescribing or if medications were discontinued. In our initial findings, we identified a total of 51 patients at both of our UWFMR clinics, 37 which were at our pilot clinic. Within our pilot clinic, 72% of all refills were done in the setting of appropriate lab monitoring. And 22% of total patients, this was 8 out of 37, had prescriptions without a significant gap in treatment during the 12-month study period. A significant gap was defined as having 1 month or more without a prescription. By reviewing our initial findings, we were able to observe that patients often had appropriate lab monitoring. We also observed that patients frequently had gaps in prescribing refills. There are multiple reasons for these gaps, such as a transfer of care to new providers or medical systems, having had short refills defined as less than a 3-month prescription, often to prompt labs, as well as missed follow-up visits or lab work and adverse effects such as a rising creatinine. Our data may not account for periods of time when patients intentionally chose to be off medications. With these observations in mind, we identified a single clinic to pilot our intervention. Our intervention included having clinical healthcare navigators or clinical staff review patient records weekly and send reminders for visits, labs, and refills to both patients and providers when due. This was introduced at weekly panel management sessions with both senior residents and healthcare navigators. Ongoing work will include assessing our intervention for its ability to meet our aim. We want to refine protocol for patient outreach for reminders for visits, prescription refills, and lab monitoring. We want to develop teaching material on guidelines for providers. We want to create clinical guidelines to be embedded into the AHR for both providers and patients. And we want to expand to include our second residency clinic that has fewer resources. In conclusion, we must balance safe prescribing with harm reduction when caring for patients on HIV PrEP. Workflows must decrease barriers to continuous treatment and adhere to evidence-based guidelines. Our model of care may be implemented or replicated at other primary care clinics. Please review these resources, which may be helpful if you are interested in starting or continuing PrEP for your patients. Thank you for taking the time to listen to our project on quality improvement at the University of Washington Family Medicine Residency.